This training provides instructions on how to recognize risk for hypermobile Ehlers-Danlos syndrome, or HEDS, and how to diagnose HEDS using the 2017 international criteria. This project was funded by the Maltz Foundation and led by investigators at the University of Arizona and the University of Illinois. We would like to thank our workgroup members who designed, developed, and executed the content for this training. You have likely treated many individuals with hypermobile EDS or hypermobility spectrum disorder, HSD, but neither you nor your patient were aware due to the underdiagnosis of both of these conditions. It is estimated that somewhere between 1 in 500 and 1 in 1,000 people are affected with hEDS, but it is challenging to get a diagnosis. Many people seek care for individual symptoms, and the clinical scope of the full disease is sometimes missed. As symptoms increase in severity and individuals experience a decline in their quality of life, they begin to seek answers for these constellations of symptoms. The Ehlers-Danlos Society reports an average time to diagnosis of 10 to 12 years for EDS and HSD. During that time, they have likely seen a variety of clinicians, including physical therapy, pain physicians, massage therapists, chiropractors, acupuncturists, gastrointestinal specialists, primary care practitioners, sports medicine, among many others, to manage their pain and symptoms. We believe that raising awareness and improving the diagnostic process for this condition can lead to earlier recognition, diagnosis, and treatment, ultimately improving the long-term quality of life for these patients. In 2017, a revised classification system for Ehlers-Danlos syndrome was published by the International Consortium on Ehlers-Danlos syndromes and related disorders in association with the Ehlers-Danlos Society. hEDS is the only known form of EDS without a genetic cause, making diagnosis difficult. A checklist has been developed to facilitate the diagnosis of hEDS in clinical settings. This checklist guides you through the process for completing the physical exam and related diagnostic criteria. The checklist contains 3 parts, including the major and minor criteria for diagnosing hEDS. Individuals who meet some, but not all of the criteria are considered to be on the same spectrum and receive a diagnosis of HSD, or hypermobility spectrum disorder. There are 3 overarching criteria. Criterion 1, generalized joint hypermobility. Criterion 2, presence of signs and symptoms. Criterion 3, evidence that other EDS rare subtypes or known hypermobility disorders and differential diagnoses have been ruled out. The following list includes a set of common markers comprised of issues commonly experienced by individuals with hEDS or HSD. We recommend when taking your clinical history, if clusters of these markers are reported, you should complete the diagnostic checklist. In addition, if you suspect your patient is hypermobile but does not have a diagnosis and you are unsure if you should assess for hEDS, you can inquire about these markers with your patient. Common markers include flexibility in multiple joints or a reported history of subluxations in one or more joints, which includes insidious cavitations or joint popping. Postural instability or trouble standing upright, frequent strains and sprains with slow healing rates, early onset arthritis, complaints of a history of slow digestion, constipation, diarrhea, vomiting, abdominal pain, allergies such as a skin rash, bladder or cervix prolapse, dizziness, tachycardia, or syncope. We are also starting to see evidence of POTS, postural orthostatic tachycardia syndrome, which is often associated with hEDS. Patient report that they have previously been diagnosed with fibromyalgia, reports of chronic fatigue, lipedema, migraines, or unexplained frequent headaches, autonomic dysfunction. The overarching criterion for consideration of an hEDS diagnosis is the presence of generalized joint hypermobility. The 2017 International Consortium on Ehlers-Danlos syndromes and related disorders have elected to use the Batten scale to classify the presence and type of joint hypermobility. The Batten scale was established in 1973 and consists of a 9-point scoring system measuring 5 different joint areas, 4 of which represent left and right sides of the body. The 2017 diagnostic criteria allow for accommodation when comorbidities such as arthritis and joint pain limit range of motion or make accurate evaluation of range of motion challenging. The Batten scale assesses the metacarpophalangeal joints of left and right fifth small pinky fingers and thumbs, left and right knee and elbow extension, and spine flexion. Joints that extend or flex beyond the established threshold receive 1 point and are summed for a score of between 0 and 9. The fifth, small or pinky finger, scores if the metacarpophalangeal joint extends beyond 90 degrees. The thumb scores if the individual can touch their forearm with their thumb. The elbow scores if extension is 10 degrees beyond plane. The knee scores if extension is 10 degrees beyond plane. The spine scores if the individual is able to place both hands flat on the floor without bending their knees. An individual meets the criteria for the following generalized joint hypermobility determined by age-based cutoff scores: greater than 6 for prepubertal individuals, greater than 5 for individuals post-puberty through age 50, and greater than 4 for individuals who are over the age of 50. If the patient is 1 point below age, they will be considered as meeting the hypermobile criteria if they answer positively to 2 of the following 5 questions. Could you ever place your hands flat on the floor without bending your knees? Could you ever bend either thumb to touch your forearm? As a child, did you amuse your friends or family by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And do you consider yourself double jointed? If an individual does not meet the criteria for generalized joint hypermobility, they may still be on the spectrum, and the full checklist should be performed. Other types of hypermobile spectrum disorders include peripheral HSD, which has hypermobilities in the hands and feet only, localized HSD, which is hypermobility in a single joint or group of joints in the same area. We will now walk you through the various elements within each feature under Criterion 2, beginning with Feature A. These elements are thought to be abnormalities present at birth and indicative of faulty connective tissue. Unusual soft, silky, or velvety skin texture can cause an increase of skin lesions, lacerations, bruising, or abnormal scarring. Feeling is that of a velvety couch or bread dough. If the skin stretches greater than 1.5 centimeters, it is classified as hyperextensible. It is important to note that skin hyperextensibility exceeding 3 centimeters is likely classical EDS rather than hEDS, which can be diagnosed with genetic testing. Unexplained striae distensi or rubeae at the back, groins, thighs, breasts, and/or abdomen in adolescents without a history of significant gain or loss of body fat. Depending on the patient's age, you can examine the stomach, trunk, legs, or upper thighs for stretch marks, or ask the patients if these manifested during adolescence without a correlated weight change. Pysogenic papules on the heel are skin-colored raised bumps on the heel. They are often asymptomatic but can sometimes be painful. The papules are herniation of fat through the dermis. You may ask the patient if these are present, or ask them to remove their shoe and load bear on the heel of their foot. Papules can be static or appear and recede with the additional load on the heel. Multiple or recurrent abdominal hernias. Hernias may be more likely in individuals who have undergone an abdominal surgery, such as a laparotomy or C-section. Individuals with hEDS can present with atrophic, non-papyraceous cutaneous scars in sites such as knees, elbows, and shins. This is positive if it involves at least 2 sites in the body. Atrophic scars appear indented and can be elicited with gentle compression around the edges of the scar. A history of pelvic, rectal, or uterine in women, organ prolapse, without a known predisposing condition, such as morbid obesity in men, children, and nulliparous women. Tooth abnormalities include dental crowding or misaligned teeth prior to orthodontics. In order to assess this, you might check for palate expanders, or if nothing is visible, you could ask the patients, have you ever had a severe overbite or very crooked teeth? Have you had multiple teeth pulled? How many teeth have you had removed because of crowding? Arachnodactyly must be present bilaterally and include a positive Walker sign or Steinberg sign. The Walker sign is demonstrated by grabbing a wrist with the opposite hand. If the thumb and pinky finger overlap, the individual is positive for the Walker sign. The Steinberg sign involves folding the thumb across the palm and closing the fingers into a fist over the thumb. If the thumb extends beyond the ulnar border of the hands, Steinberg sign is positive. An arm span to height ratio that's longer than 1.05 is a connective tissue sign that is supportive of hypermobility and hypermobile EDS. Have your patient stand against the wall and take a measurement from the longest fingertip on one hand to the same finger on the opposite hand. Divide the wingspan measurement by height. If the ratio is greater than or equal to 1.05, this element is positive. Mitral valve prolapse and aortic root dilation score of greater than +2, documented by echocardiography, is positive. Ask the patient about previous history of cardiac symptoms. Do you have cardiac issues? Do you check your heart rate and resting heart rate often? If yes to cardiac issues, refer to cardiologist. If yes to heart rate issues, consider POTS. If a patient has a first-degree relative who has been diagnosed using the 2017 criteria, score as positive for feature B. Please note that only first-degree relatives qualify. First-degree relatives share approximately half of the genes and include biological parents, siblings, or children. There may be family members who show many of the symptoms of hypermobility, but only those first-degree relatives diagnosed by a qualified medical professional using the 2017 criteria count as positive for feature B. Frequently, the patient you are assessing will be the first individual in their family to receive an hEDS diagnosis. Feature C includes the hallmark feature of hEDS and HSD, which includes pain and/or frank joint instability absent preceding injury. Pain is considered positive if it occurs for 3 months or longer and occurs in at least 2 limbs or is described as widespread. Joint instability is defined as chronic dislocations or subluxations, which can feel like the joint gives out, or frequent hyperextension. This can also present as involuntary joint cavitation caused by normal movements. And finally, if the patient is experiencing recurrent joint dislocations or frank joint instability without having experienced trauma. Criterion 3 rules out all other more common differential diagnoses associated with joint hypermobility. However, there are tests that all patients considered for hEDS should undergo if they have not been previously performed. First, a basic serology rheumatological screening, including ANA, HLA, B27, and CRP-ESR. If there are positive results, refer for consultation with rheumatology for evaluation and management. An echocardiogram, if positive, it's recommended to consult with pediatric or adult congenital cardiology for evaluation and management. Scoring criterion 3 requires results from the tests described above, and an hEDS diagnosis requires that all 3 elements are met. First, the absence of unusual skin fragility or the propensity of the skin to develop blisters or abrasions with only minimal mechanical trauma. Patients may describe having paper-thin scars after minor scrapes, which should prompt consideration of other types of EDS. 2, exclusion of other heritable acquired connective tissue disorders, including autoimmune rheumatologic conditions. It is important to note, if the patient already has a diagnosis of rheumatoid arthritis, lupus, or any other autoimmune or rheumatological disease, then pain under criterion 2, feature C, cannot be used as a qualifying feature in an hEDS diagnosis. Scoring diagnostic criterion for 2 for hEDS with comorbid rheumatological disease is only possible with objective signs and family history, which are features A and B. Most connective tissue disorders cause joint hypermobility with objective signs of connective tissue differences. Thus, it is important to differentiate hEDS from other connective tissue disorders, including the other 12 out of 13 types of EDS, Marfan syndrome, etc. The goal of criterion 3 is to clearly identify hEDS from these other conditions. Other types of EDS are rare, but can be diagnosed through genetic testing. Considering alternate EDS diagnoses if any of the following are present. Individuals with skin stretching greater than 3 centimeters at the volar forearm, consider classical EDS. Any individual with a history of scoliosis requiring surgery or causing short stature, consider kyphoscoliotic EDS. Individuals with good dental hygiene but experiencing dental loss before age 20, consider periodontal EDS. Individuals with history of aortic dilation or vascular ectasia, consider vascular EDS. And 3, exclusion of alternative diagnoses that may also include joint hypermobility by means of hypotonia or connective tissue laxity. Alternative diagnoses and diagnostic categories include, but are not limited to, neuromuscular disorders such as Bethlem myopathy, other hereditary disorders of connective tissue such as Loeys-Dietz syndrome or Marfan syndrome, and skeletal dysplasias such as osteogenesis imperfecta. See the differential handout provided with the course for guidance. Family history of any alternate positive genetic test result should trigger consideration of a differential diagnosis. Geneticists will typically only order molecular genetic testing on a fraction of people that they evaluate for hEDS. This is only positive or useful in cases where there are unusual features or a high probability of vascular EDS. Someone with fainting or syncope, especially if it is occurring frequently, should also be sent for cardiology referral. Anyone with aortic dilation, vascular ectasia, decreased ejection fraction, or hypertrophy on echocardiogram should be immediately referred for cardiology. Someone with high myopia and any loss of vision should be sent urgently to an ophthalmologist to assess for retinal detachment or lens dislocation. Thank you for being part of that change in decreasing the time to diagnosis for hEDS and HSD.